become synonymous with clear, concise teaching in the field of clinical genetics. We have heard her so often in national platforms, and yet each talk of hers brings something new and meaningful. Ma'am, we are delighted to have you with us today. Please, could you start with your talk?
Thank you, ma'am. Thank you, Upma, ma'am, for this opportunity. It's a very interesting topic.
Can I just
And
say one word about Veronica, if you allow me?
Yes, ma'am.
I'm proud because Veronica happens to be an alumni of the same college as mine, if I'm not wrong.
yes,
Veronica,
ma'am.
it's KMC Mangalore. So
Yeah,
we are both alumni of the same college. So
yes.
really proud of the fact that you're doing so well.
Thank you. Thank you. Thank you so much.
Welcome, Dr. Anjana.
So,
very good evening to everyone.
Good evening.
Good evening, ma'am.
okay.
I hope I'm on time.
Yes, ma'am. Yes,
They are
ma'am. You're
not
right.
behind time. So, for Upma ma'am's love, I'll make my talk even shorter than it is and give just the clear messages that
Yeah,
and some introductions, right? So we already, I think, to this audience, we do not need to tell the importance of Rh negative and the frequency, which is much higher in the Caucasian population for sure, but the burden is now rising in India as well. The prevalence of HDFN in India is approximately 1 in 20,000 live birth. It has definitely become better after the introduction of anti-D. It affects approximately 4,000 fetuses worldwide each year, and 15% of these die before birth. Still, at a tertiary care center in Gangaram Hospital, we do get cases maybe once in every 2-3 months where there are multiple deaths and the blood group is still not done. So before we reach the genotyping, definitely we need to do the blood groups for all. So let's learn a little bit about the genetics of RHD, because we are really focusing on this in this webinar. So this rhesus D antigen is the most important blood group antigen determined by the protein anti-D, which remains the leading cause of HDFN. The antigen is carried by the proteins, and there are two main genes, the RHD and the RHCE. So because there are two important and homologous genes, any mismatch in any of these genes can cause an Rh incompatibility. So these RHD gene is flanked by two homologous DNA segment. Homologous means that they are almost same in their constitution. In white people, the D negative phenotype is usually due to a deletion in RHD gene that had occurred by an unequal crossing over. So there has been a lot of conjecture about why this D antigen became so important and persisted when the minor blood group antigens like C or E are less important. So the detection of this hybrid rhesus box, as we call it, has been applied to demonstrate the presence of the RHD deletion. Now, when this deletion is absent, a person becomes an Rh negative person when it's present. Hence, it became feasible to distinguish between the RHD homozygotes, that is the Rh plus plus, from RHD heterozygotes, that is the Rh plus minus. So both the homozygous people and the heterozygous people would have an Rh positive blood group, but by genotyping we can determine that if the deletion is present or absent, and if it is present, then we can go ahead for testing. So such discrimination is of clinical interest, a plus plus and a plus minus differentiation, because all children of an RHD homozygote father will be RHD positive and at a risk of HDFN if the mother hasn't produced an anti-D. That is, if the mother is negative and is having a second pregnancy. The risk of an affected child is 50% when the father is heterozygote for RHD. Right? So when we have a father that is heterozygous, that is when we need to go and test the baby. So now in India, it is seen that 26% of the women whose husbands are Rh positive by serology And heterozygous for RHD deletion by molecular method require fetal blood group determination from maternal plasma. Hence, knowing this RHD zygosity of the husband, fetal group determination from the maternal plasma is required to be done in 1/4 of these women having the plasma. So we have two conditions. When a father is plus plus, that is the blood group is positive and there is no deletion that is present, and the mother is negative, definitely, right? So in such a case, we will not test this couple and the fetus of this couple, because we know in either case the fetus will be Rh positive and we need to give the antigen. But we will do the genotyping of the father, only then we will know that this is a positive case. So the first step in testing is always the genotype of the father. In cases where the father is a plus minus, that is Rh antigen is present on one copy of the RHD gene and it is deleted on the other copy of the gene, due to the unequal crossing over that we spoke about, the Rh deletions are common. In that case, there is a 50% chance that father gives a negative allele or a deleted allele, and the 50% chance the father gives a positive allele. So in this case, we genotype the father, first take the blood of the father and then we take the blood of the mother to determine the fetal blood group. So earlier it was only possible by taking a cord sample or an amniotic fluid sample, but like NIPS has revolutionized antenatal screening for aneuploidies, it has also paved its way for Rh negative pregnancy. The important part of the blood that was not being looked at earlier, that is the plasma of the blood. We kept on looking at the leukocytes, RBCs, and looking at that part and looking for revolutions in that. But the plasma, it is what had the cell-free fetal DNA. So the cell-free fetal DNA technology became the standard of care in allo-immunized women in England in 2001. So now, also by the NICE guidelines and the other important societies have made it an important screening test for women. So we all know that the cell-free fetal DNA comes from the fragmented DNA, which is 200 base pair in length, and we can start testing at 5 weeks. And the best sample that and the best and the earliest both together, if we see, we can obtain at 11 weeks. So NIPT or NIPS was initially for Rh negative women, and of course now it's more commonly used for our aneuploidy screening. Now if we compare the Rh screening test, that is the what we test for anti-D, and if we compare it with the Rh diagnostic tests with the genotyping, we can see that there is a much higher sensitivity and specificity when we are using the RHD as a diagnostic testing, and specifically the specificity goes higher and we can make treatment related decisions. So here is a flow chart of how we can approach such women. So initial testing we do, and the mother is Rh positive. We do not need to do anything further. Mother is Rh negative, but antibody positive. Again, confirmatory Coombs test and follow up. But when the mother is antibody negative, in that case, a paternal Rh genotyping should be done. So you have a couple with Rh negative woman, Rh positive husband, ICT negative. In that case, you can go ahead and ask them if they would like to know the blood group of the baby. If the father is Rh positive, there is a 50% chance of Rh positive fetus if the father is plus minus. And in that case, we can go ahead by this non-invasive testing of the fetus to predict the fetal blood group by the deletion I spoke about. So this NIPT for fetal Rh genotyping has a role in two categories of women where alloimmunization has occurred And the third category is for matching of RBC product where intrauterine transfusion is required due to maternal allo antibodies. So I will just show one slide. So the management strategies in transfusion medicine, as we know, are designed to prevent alloimmunization in women with childbearing age or treated appropriately when it has occurred. So there are many categories which were presented, and consequently, finally, a three category rule was given. So the first was for women within the childbearing age requiring a transfusion. The primary category is red cell transfusion with antigen matched or antigen negative red cell product to prevent exposure to clinically significant antigen. For Rh negative women that gave birth to an Rh positive infant, the second category is postnatal RHD immunoglobulin prophylaxis as well as antenatal prophylaxis to prevent immunization during pregnancy. And the third is where alloimmunization already has occurred. So NIPT for fetal Rh genotyping has a role in categories 2 and 3 in both screening and diagnostic settings, when NIPT for genotyping for other atypical blood groups is limited within category 3. So we can predict the amount of mismatch as well as if it is going to happen as well. So NIPT RHD as a diagnostic test is now nearing 2 decades of experience. It's recommended that all pregnant women have a blood group and an antibody screening performed in every pregnancy. Women presenting with anti-D levels of greater than 4 or any red cell allo antibodies are considered to be clinically significant. Without knowing the Rh fetal status, the pregnancy will be managed as a high risk pregnancy always and will require regular fetal ultrasound surveillance. The availability of this non invasive technique, the genotyping, permits assessment of fetal Rh cord blood status without actually pricking the fetus. So there are, of course, some challenges for the NIPT fetal Rh genotyping because this RHD gene is highly polymorphic, that it keeps changing its architecture. The laboratory needs to have done a lot of sampling and validation for them to give you a correct result. The specificity is good, but the sensitivity to pick up it's still not 100% like all other NIPS testing. Fetal RHD genotyping assay captured these variants by amplifying 2 or 3 RHD exons, and the part of the genes that are not amplified and that are not taken into account, that may give us a falsely positive result. So fetal genotyping by NIPT potentially has an advantage over phenotyping by cord serology because cord serology may not detect paternally inherited variants associated with the weak D phenotypes. When we look at the cord blood, it is mostly showing us the strong anti-D variants. NIPT, because it does a genome-wide sequencing, shows the small d, capital D, C, E, all the variants. So when do you do the test? You can do this test between 12 to 24 weeks of pregnancy. We would require the blood of the father and the mother. Ideal preferred time is to do between 12 weeks to 14 weeks. What is the advantage of this test? First is that in some pregnancy, the serology shows Rh negative pregnancy, and actually the genotype shows a plus minus or even a plus plus. So there are false negative blood grouping done even on serology of husbands. And you may think that the husband is Rh negative, but on genotyping, we find that because of increased sensitivity, that 1% cases where the serology is false negative, we can help the couple. So among the Rh negative pregnancy carrying an Rh negative fetus, over 90% are unnecessary Rh immunoglobulins which are given. Darlington et al. Reported 93% of not at risk Rh negative pregnancies which were given the Rh immunoglobulin, and this technique of genotyping helped us to avoid this unnecessary immunoglobulin being given to this study in the genotypic arm. After non-invasive fetal RHD blood group genotyping in all studies, a small proportion of people received RHIG upon request. So, of course, there were some people that even if it is negative, the blood group of the fetus, people still like to go for it. But there was a 93% of those people who did not want to take it further. So now, in alloimmunized pregnancy, we have invasive procedures are avoided like amniocentesis, CVS, chordosynthesis, and the frequency of hospital visits and blood tests are reduced. The maternal quality of life is better, and adverse effects of testing or intensive monitoring and interventions are reduced. The implementation outcomes such as procedures are missed. In non alloimmunized pregnancy, we can avoid the unnecessary RHIG. Risk of alloimmunization, which occurs due to immunoglobulins, the maternal quality of life is better. Adverse effects such as infection or reaction from immunoglobulins and the burden of the cost of these measures for the government also decreases. It has been estimated that $150 million could be saved by performing this screening test in Canada. We do not have such data from India yet. Immunoglobulin is a blood product, and knowing the genotype being negative saves us from giving the woman an inadvertent blood product. Through effective and having a likelihood of adverse effects, RHIG prophylaxis is definitely not without risk. The scenario in India is completely different. We actually are encouraging an RH immunoglobulin for all. We are reaching that part that we are trying to make sure that this RH negative women receive this. But we also, in the meanwhile, in the background, in the setting of knowing that the world has advanced, and at least for fetal medicine specialists, it is important to offer these tests so that the awareness of these tests also slowly increases on the path of development for a better obstetric care. So there are also risk of anemia. The classification of risk of anemia by paternal phenotype and NIPT permitted reduced monitoring, reduced cost, and reduced maternal anxiety, and without compromising perinatal and neonatal outcomes. So we are not doing the classification of fetal anemia, or even we are not dealing with the alloimmunized pregnancy. As I showed, the advantages there, we at present are only helping in telling you if the baby is Rh negative or positive, and not for the prognostication as yet. We can also pick up minor blood group mismatches, and by the KEL, RHC, and RHE group mismatches. This algorithm I have already discussed. We do a maternal antibody titer, and if it is ICT negative, we do a fetus's father's genotype, and for a homozygote, we just go ahead and do the MCAPSV, and for a heterozygote, we do a cell-free fetal DNA on the mother or an amniocentesis, whatever they prefer. So finally, the practical points, the ideally the test should be done between 12 to 16 weeks. We want an EDTA bladder of the blood of the father and the mother. A 3 ml EDTA blood would be fine. Initially do a paternal genotyping by the PCR test and sometimes by RFLP. The cost is around 3 to 4,000 rupees. And if the father is plus minus, we go ahead and test for the fetus. Thank you so much for the patient listening.